For those who don't know, I'm Dr. Kostas Kafalis, and I will serve as your moderator for this evening's program, COVID Concerns and Questions, a parish seminar with medical experts. It is my privilege to serve as the founding president of the Holy Unmercenaries Medical Society, also known as HUMS, at Annunciation, Akron. Our medical society was recently formed and has the purpose to provide our members the opportunities for worship, education, service, and philanthropy. And on behalf of our board, we are pleased to present this program on COVID-19 to our community. Thank you all for joining us this evening, and many thanks to those who submitted questions beforehand. We intend to answer all of them, and we'll probably take the whole time to do so. Because of the nature of the seminar, we are not going to be able to take live questions, but you may submit questions via the chat function of Zoom. Again, depending on timing, we may or may not be able to get to those this evening. At this time, I'd kindly request that everyone turn off their microphone and go to the mute function so that we hear no feedback as we begin the program. In addition, this session will be recorded, and if you do not want your image shared on the recording, please turn off your camera at this time. Now I'd like to ask Father Jerry to offer an opening prayer for the program. Father.
Thanks, Costa. In the name of the Father, and of the Son, and of the Holy Spirit, amen. We thank you, O God, for the many blessings you bestow upon us. We thank you especially for the blessing and gift of healing that comes from our connection with you. We thank you for blessing those who serve as healers in our community. We ask you would continue to guide and direct them. We ask your blessing and protection and healing upon those who are suffering with the coronavirus. We ask your protection upon all of us and your guidance and strength for all of us through this difficult time. Guide and direct the hands of all those who work to effect the cure of the ailing, and bless our time here tonight for the glory of your holy name, Father, Son, and Holy Spirit. Amen.
Thank you, Father. It is now my pleasure to introduce our panel of experts. First and foremost, Dr. Thomas Feil, who's the chair of the Infectious Disease Division and co-director of the Antimicrobial Stewardship Program at Summa Health. Dr. Feil is also a professor of internal medicine, master teacher, and chair of the Infectious Disease section at NeoMed. Dr. George Kafalis is the president of the Pulmonary Physicians Group in Canton. He's the medical director of the Cardiovascular Surgical ICU Intensivist Program at Altman Hospital, and he is an assistant professor of internal medicine at the medical school NeoMed. Dr. Chris Kyriakides is an attending emergency physician at Mercy Medical Center, professor of emergency medicine at NeoMed. Ms. Melanie Morris is a nursing operations manager at the Cleveland Clinic, Akron General. Dr. Alex Nikolazakis is on the medical staff at Ohio's Hospice Life Care. Dr. Jim Salem is the head of endocrinology and metabolism at Summa Health, and he is a clinical professor of internal medicine at NeoMed. Dr. Julie Tserambides is director of advanced practice providers and pediatric and family nurse practitioner at Akron Children's Hospital. And of course, Father Jerry, whom we all know, is also going to be taking some questions from those listed this evening. So with that, we'll start our program and ask Dr. Feil the first question. How is COVID-19 different from the flu?
Thanks, Kostas. Before I answer that, I just want to say I think this is a great idea to do this. I think the more information we have, we can make better decisions. And so this is very helpful to disseminate information such as this. I also want to disclose that what I say totonight, because the information is changing so much, we're learning every day about this pandemic, about this virus. So what we say tonight may not be totally accurate even a month from now, but at least what it is now, we're going to give you the best information so everybody can make good decisions. Okay, as far as the question about influenza versus COVID-19, which is caused by the virus SARS-CoV-2 number 2, basically the symptoms are very similar. And that's a challenge for us as clinicians when we start to see influenza in the community, which, by the way, we really haven't seen yet. And it may be because of our use of masks and distancing like the Southern Hemisphere last winter for them, they did not see much influenza. But this is going to be a bit of a problem because we treat, obviously, influenza differently than we treat COVID-19. But both of them, as I said, have similar symptoms from the standpoint of relatively acute onset of fever and chills, headache, muscle aches, cough, shortness of breath, et cetera, et cetera. And so from the standpoint of a syndrome, it's difficult. I would have to say, however, with COVID-19, the amount of manifestations or symptoms are much more variable. We'll see GI, gastrointestinal symptoms, as you know, Costas. I mean, initially nausea, vomiting, then somewhat later diarrhea. Of course, a big difference that I'm sure many of you are aware is the symptom of loss of taste or loss of smell. I mean, that is much more associated with COVID-19. But as far as the difference, well, number one, the incubation period is a little bit different. When you're exposed to somebody with influenza, usually the incubation period, at least after you've been exposed to the person, you're going to develop illness probably within about 2 to 5 days, not be longer than that. As we know with SARS-CoV-2 or COVID-19, the incubation period is much longer, it goes up to 14 days. So that makes it a little bit different. We certainly know that the transmissibility or the contagiousness of SARS-CoV-2 is much higher than influenza. If you look at what we call the reproducible score or rate, which means that if somebody has the infection, what is the likelihood of how many other people they may infect? For influenza, it's about 1. So that if you have influenza, you may infect another person. With COVID-19, it's more like 2 to 4. So you can see that there's a potential higher for transmissibility and spread. And of course, as I think I mentioned, there's a difference in treatment. I mean, for influenza, we have a well-established therapy that is approved that we can use both in the community, oral medicine versus as well as in the hospital. For COVID-19, there's only one approved by the FDA intervention, and that's an antiviral agent called remdesivir. Now, there are other modalities that have been authorized by the FDA under what we call emergency use authorization, but basically those are the differences.
Thanks, Dr. File. Question for Dr. Kafalis. If I'm at home with COVID-19, when should I consider going to the emergency room?
Thank you very much, Costa, and to all the other panelists, Father Jerry, and all of the community members who are participating today. It's really an honor to be able to have the opportunity to speak with you. This is a common question that I receive in my practice as a pulmonary specialist. And in the end, of course, we always advise patients to talk to their doctors. The symptoms that do raise concerns, of course, are increasing shortness of breath. That is certainly out of proportion to what a patient may feel at baseline. I have a lot of patients with chronic lung conditions, so shortness of breath is a daily problem for them. So this is why having a conversation with your personal healthcare provider is probably the most important thing to do. But certainly there's challenges with communication sometimes on weekends, after hours, et cetera. And if someone has been diagnosed with COVID-19 and has worsening shortness of breath, this is the symptom that's probably the most concerning, which could be a manifestation of low oxygen levels or progression of disease that may warrant treatment in an inpatient hospital setting.
Thank you, George. Dr. Kyriakides, what are the most common symptoms that you encounter in the emergency room in patients that are presenting with COVID-19?
I think Tom and George both mentioned it's definitely shortness of breath. That's a symptom that is kind of universal. Most of them are that, unless it's a child presentation. I've noticed over time that it seems to be abdominal pain with nausea, vomiting, and diarrhea. But shortness of breath by far brings them in. I think early on in April and May, I had a lot of people that were false negative testing that all had taste changes. So I don't know if people imagined it or they had it, or I'm just not testing and capturing it. I don't know. But that seems to have dissipated in of all the hospitals that I work in different cities. By far, shortness of breath is the symptom, and the sign is hypoxia, or low oxygen.
Thank you, Chris. Melanie, something that has come up, and we'd certainly love to see your demonstration of this, is in terms of the masks. How should we properly wear a mask?
So I have to say, this is probably one of my biggest pet peeves, is to see people thinking that this is the way to wear a mask, and it's not. There's a lot of different kinds of masks. What I have here is just the regular, oops, and this isn't going to work very well. This is just a regular surgical type mask that you can get, the throwaway ones. Marks has them, everyone. They've got the little wire at the nose. And so you put it on, pinch the nose so that you're closed up here. And if you wear glasses, that's very helpful, because then you're not fogging up your glasses if the nose is pinched. And you should tuck it under your chin, so it doesn't get worn like this. It doesn't get worn like this. It goes like this. You probably might have a little gap on the side, and that's fine. It's not supposed to be all encompassing and tight exactly to your face. That's what the medical people are going to wear when they are the N95s, that they go through fit testing to make sure that they're not having any leak of particles. So there's actual testing to make sure that they're wearing it correctly and can put it on and off. Everyday common people, N95s, if you want to wear it, go for it, but something like this is fine. You can also wear just plain cotton masks. This is one from Target. It's kind of t-shirt material, but it's 2 layers, because you want to have 2 layers, 3, 4, 5 layers, more than that, and it's going to get really difficult to breathe. Again, this one, it's not good for me because there's no wire up here, so it doesn't allow my glasses, they fog up all the time. But you can see that it's close fitting, but it's not overwhelming my face. You want to make sure that your nose and mouth are covered. You can get some like this that people will make with little ear loops. You can get some with ties. You want to make sure that it's not too small for your face. I don't have a mask that's too small because they all fit pretty well. But you can see all different kinds. You don't have to have something that costs $15 or $20. Again, these, you can get a box of, 15 or 20, up to 50 of them for not very much money. The one thing that I will say, please, when you throw your masks away, cut the straps, because as they're going into the landfills, as people are leaving them laying in the parking lots and whatever, animals are getting caught up in the straps, and it's not very nice for them. Birds and other animals can be injured by that. Finally, make sure you're washing your mask. You need to be washing it technically every day when you wear it. If it's a cloth mask, you should wash it out every night. Just soap and water in the sink, hang it to dry, and then in the morning you're good. These other masks, one-time use, wear them and throw them away.
Thank you, Melanie. We're going to go back to Dr. File for the next question. We're going to do this a lot this evening. And I forgot to mention in my introduction of Dr. File that he served as the president of the Infectious Disease Society of America last year. He's currently the immediate past president. So question for Dr. File: what is the current status of the Akron hospital systems today in terms of ICU bed availability, critical care staff, et cetera?
Well, that's a great question. And right now we're getting close to being overwhelmed. I think we're all able to do what we can with what our capacity is right now. But all of us are seeing so many increasing of cases, that we've had to even relocate nurses. I think the biggest threat right now is not so much beds, but it's our staffing in order to take care of patients. And let me just give you an example of the magnitude of which we're seeing cases now. I mean, in September, we were averaging maybe somewhere between 10 and 20 cases a day in the hospital. The end of October, we were up to about 40 to 50. Yesterday, we had 190. I mean, I just want to show you how, and this is all of our hospitals in Northeast Ohio and in Canton, Akron, et cetera, are experiencing this. So this is something that we're all dealing with, trying to make sure that we have adequate capacity, adequate beds, but most importantly, adequate healthcare professionals, nurses, respiratory therapists, physicians to take care of all of our patients, because it's not just the COVID patients. And although it seems like when I go into the hospital every morning, it almost is like a COVID hospital, but about 40% of our patients now are on COVID various units, but we still have to take care of the other patients. I mean, those that have heart attacks or strokes or other conditions that need to be cared for, and we're able to do that right now. But I mean, we're struggling to keep up with that. So it's really important for everybody to be aware that to do whatever you can to reduce the spread within the community, so we don't really overwhelm our healthcare facilities.
Thank you. George, just for comparison down at Altman, can you share numbers today versus September or versus July? You're on mute, George.
Sorry about that. Absolutely. Our numbers are mimicking the Akron numbers. We're all part of Region 5. And as of yesterday, NICO is the kind of regional conglomerate of hospitals that shares data with the state that then gets reported out. And for our region, our ICU bed capacity is occupied by about 82% at this point in time. Just as an example, when this pandemic started and had our peak in May at Altman Hospital, we have a 20-bed medical intensive care unit. And we had at most, at worst, 8 patients that were in the ICU and about 25 patients total. As of today, we have 113 in the hospital, and I'm rounding in the ICU and have done so for the last week and a half. And we had 18 out of the 20 beds that were patients with COVID. Now, the good news, we extubated 2 people, got 2 people off life support, but we got 2 new patients that came in that we put on life support. So it's certainly a surge right now, and certainly the demographics have changed. In the spring, it was certainly a condition that was affecting patients in nursing homes older than 75 to 80 years of age. Today, when I made my rounds, 80% of the patients were less than 70 years old, with the youngest patient that I had today, 21 years old, on a ventilator. So it's certainly a different demographic condition now compared to 8 months ago. And I echo what Dr. File said in terms of everything needing to be done to try to halt the progression. Although, as we know, we're about 2 weeks behind. And so we're really worried about the next 2 weeks with the recent Thanksgiving holiday and the potential for an even bigger surge going forward.
Thank you, George. Dr. Nikolazakis, question came in. Can coronavirus affect your heart and how?
So any virus, well, I should say any virus, but there are many, many viruses that can affect the heart. Even the common cold, influenza virus. There are many viruses that can get to the heart muscle and cause damage, weaken it, and end up with a resultant, what we call viral cardiomyopathy or weakening of the heart. The coronavirus, with COVID-19 though, what's been seen is this cytokine mediated storm or cytokine mediated myocardial injury. In other words, this virus gets to organs, and the heart is not the only one, the kidneys, obviously the lungs, and this reaction that occurs is damaging heart muscles and can weaken the heart muscle and cause heart failure. That's one way. Another way is just simply by virtue of the fact that these patients are not oxygenating well. and the low oxygen levels in the blood, the hypoxemia can cause heart attacks, which are called type 2 myocardial infarctions. In other words, there's not enough oxygen going to the heart muscle. So that can damage the heart in a different way. Also, there's a prothrombotic state, a hypercoagulable or clotting state that can occur with COVID-19 that is also thought to be a mechanism in causing these non-STEMIs, these myocardial infarctions and damage. But there are also other things just with the influenza. I mean, I just remember a couple of years ago when we had the influenza outbreak and the hospitals were full of influenza. We were consulted almost daily, 2, 3, 4 times a day on patients having arrhythmias, atrial fibrillation. So that's another common sidelight of the infection. So yes, it can affect the heart in multiple ways.
Thank you, Alex. Along the lines of other parts of the body being involved, this question is for Dr. Salem. Why do patients who get COVID-19 and have diabetes do more poorly than other patients?
Why can't the endocrinologist manage to unmute his microphone? So I took over our service, our inpatient service, 2 days ago. And just as Dr. File was remarking, the number of patients was remarkable. Patients who have diabetes are 2 to 3 times more likely to be hospitalized if they have COVID. And they're about 3 times more likely to perish, according to some studies. As Dr. Nikolazakis mentioned, there is an inflammatory state that is part of the lethality, the lethal nature of COVID. And patients who have diabetes have a baseline sort of pre-inflammatory state. So markers that look at the inflammatory condition of your body, like interleukins and also the propensity to clot, are higher in patients who have diabetes than in control patients, and then in patients who don't. So because of that, they sort of go into it in a weakened condition, so to speak. So there's the initial infection, and then there's the inflammatory state that follows, the cytokine storm, and our patients with diabetes are already prone to getting that. In addition, our patients with diabetes tend to have other factors that limit how well they can do. Patients with diabetes tend to have obesity, which in and of itself is a risk factor for poor outcomes with COVID. Even patients with obesity and type 2 diabetes tend to be vitamin D deficient, which is in some way related to poor outcomes. So there are multiple reasons that patients with diabetes do more poorly.
Thank you, Jim. Question for Dr. File regarding testing available for COVID-19. Which test is more accurate, the swab or the finger prick? Perhaps, Dr. File, you could give us a brief overview regarding testing for coronavirus.
Well, testing is very important so that we know how we can identify patients and therefore treat them appropriately, and then actually quarantine them or isolate them or whatever, so we can stop transmission. So testing is very important. And I can tell you, we're still having a difficult time with capacity of testing now as we're surging, particularly trying to test everybody in the community. But the main test that we do that's the most accurate is what we call the PCR test. Now that's just a test where you do a nasopharyngeal swab. It's where you take the swab and you put it in the nose, but you direct it all the way back to the pharynx. So when I do this on patients, they think that I'm going right to the brain. But nevertheless, I mean, it's not the most comfortable, but that's the most accurate test to do. And what this does, it actually measures nucleic acid, which is your basic sort of DNA, RNA type of genetic makeup of the virus. And it's a very sensitive test. It doesn't necessarily mean that you're actually identifying a infectious virus. It just means you're identifying nucleic acid sequences of this virus. But that's the nasopharyngeal swab. Now, if you just do a nasal swab, it's somewhat less sensitive and less accurate. There are some studies looking at, throat swabs, saliva or whatever, but those yet are not really useful generally. As far as a pin or a needle prick, I mean, that's actually measuring or obtaining blood. And if you're going to use blood, what you're going to measure there are antibodies, not necessarily specific identification of the virus. You're measuring antibodies that the patient makes against the virus. So that really is not going to be useful for diagnosis. That can be helpful in determining if a patient was exposed in the past, but still it's the nasal or the nasopharyngeal swab that is routinely used to make the diagnosis of SARS-CoV-2 or COVID-19.
Thank you, Tom. Question for Dr. Tsourmbidis regarding children. Are kids getting COVID-19? And along those lines, can kids have COVID-19, have no symptoms, and then spread it to others?
Hi, everybody. So I'm bringing sort of the perspective of the other end of the spectrum from what everyone's been sharing. And we have been consulting with Dr. File and team, and my senior leaders work with the NICO group. So yeah, kids do get COVID. And early in this, we really weren't seeing too many cases, but now we certainly have had quite a surge. Most importantly, since the Halloween timeframe and now Thanksgiving that everyone is talking about, we've had that increased surge and we are nearly full. Our hospital and our ICU is actually now have children admitted. So while kids do get COVID, we actually are now starting to see some of the MISC, the infectious component and the inflammatory component, the MISC that kids are getting in our ICU. We actually do have that now. The majority of kids have mild symptoms and some actually have very little. I think, as my uncle has said, in the emergency room, we're seeing a lot of the abdominal and GI types in the primary care setting. So that's what I have seen mostly when they come in with very mild symptoms and mostly directly related to being around someone who has tested positive. So these kids don't necessarily know they have it. So they've either have had family around, maybe with the recent holiday, they were in a home and you weren't masked or distanced. And so they're transmitting, and kids are germ fests. So in general, when they have viruses and runny noses and goopy hands, they transmit viruses all the time. But in this regard, we're definitely seeing a lot more positive cases now.
Thank you, Julie. Question for George. What characteristics increase the chances of a patient with COVID-19 requiring ICU care? You mentioned shortness of breath and others mentioned hypoxia, but what other features or symptoms that you see in patients, perhaps that are admitted to the hospital, a regular hospital floor, that raise the risk of needing ICU care?
Well, I can say as this pandemic has evolved and we have seen the surge of patients here over the last 2 months or so, patients have to be really sick to be admitted to the hospital anymore. You have to demonstrate a significant amount of low oxygen levels, significant dehydration associated with some of the gastrointestinal symptoms, or other confounding factors like changing mental status or confusion. I can tell you that at our hospital, many of our step-down units, which is a level of care below intensive care and one level above regular floor, the step-down units right now are functioning like intensive care units. There are patients, tens of them, on the step-down unit who are receiving high-level support with oxygen support, who a year ago we would never have dreamed to have on a step-down unit. They would have been in intensive care. But because of the nature of this surge, we're having to basically move the ICU to the step-down areas and have our team supervise the care for those patients. Early in the pandemic, we treated the patients who had severe respiratory failure from COVID. As we treat other patients who have respiratory failure, we put them on respirators early. We had certain techniques to use the ventilator to try to protect the lungs, but what we found out is we were probably causing more harm in those patients. And I'm sure many of you have seen some of the popular press describing how the ventilator itself could also cause damage, which could then increase the risk of dying from this condition. So now our focus is trying to keep people off of ventilators using BiPAP and CPAP masks that many people may be familiar with from sleep apnea, those types of devices, as well as high flow nasal cannula devices, which is basically highly concentrated humidified oxygen that we could administer to these patients. Now, the decision then to move the patient to the ICU and put them on a respirator kind of depends upon how they respond to those treatments. If we see that the patient's work of breathing, they're struggling so hard to breathe with those measures, that's one indication to go ahead and proceed with putting them on a respirator. Also, if we cannot keep their oxygen levels where they need to be with those modalities, then intubation and moving to the ICU is what we do. And then finally, this change in the mental status and confusion. A lot of times patients can become quite confused with all of these different treatments, being in a room alone in unfamiliar surroundings, to start ripping off masks, ripping off oxygen, which obviously is not something that is going to be a good thing for that patient. So that's another indication for us to move in and put the patient on the respirator. Honestly, when we take patients off of ventilators in the ICU, within 12 hours, we try to move them out to the floor because we know we're getting more patients that are going to need the ventilator. And then we just rely on our colleagues on the floor, my partners, other nurse practitioners, and hospitalists that are rounding to take over the care and truly have outside of ICU.
Thank you, George. Question for Father Jerry. With regard to disease transmission and Holy Communion, are we still drinking from a common cup? If so, why?
There has been, thank you, Costa, for all of this. And so in terms of the sacraments of the church, I mean, much has been written about Holy Communion during COVID, but I think all of the sort of theologians and writers who have talked about this, really, we come back to our theology that Holy Communion is not something that is a transmitter of disease. Now, that's not to say that, you know, people aren't coming to church or aren't coming to churches and are contracting, you know, COVID. But we really think that, I mean, we look at it like it can be at other ways in which, you know, people are coming in contact with one another. And so we've tried to make some, you know, some smart changes. The metropolis has, you know, looked at the way in which we actually give Holy Communion to others. And so out of an abundance of caution, the bishops have allowed and some recommended, you know, offering communion as we do in our parish by people just opening their mouths, and then we are just sort of depositing the Holy Communion onto their tongues without them really having contact with the communion spoon. And so, you know, we're doing all of these things to help people have this encounter with Christ, with God, in the safest way possible. Our patriarch, you know, has made some publications as well from the Holy Synod, you know, again, issuing similar statements that when we receive Holy Communion, that this is something sacred and holy, and we just don't see it as something that is a transmitter of disease. But I think the care that we've tried to exhibit within the parishes is to, you know, like do things that makes people safer in these other ways, in terms of people wearing masks and keeping people, you know, providing a safe distance between everybody that's in church, really restricting how people are passing one another and these kind of things. And so, you know, so those are the ways that the church has tried to deal with this. while maintaining still our position and our theology that Holy Communion is a sacred encounter with something that's life-giving.
Thank you, Father Jerry. A question for Dr. File. Please comment on the CDC recommendations for returning to work after COVID-19, as many have ongoing fatigue and are not able yet to work and are being held by their employer or being asked by their employer to return to work.
Okay. Well, there's two things here. I think, first of all, what is the duration of potential transmissibility after somebody has COVID? There's very good studies now that clearly show that after 10 days after the onset of illness, a person who has had COVID-19 is no longer contagious, no longer transmissible. So that's number one. So we would allow, obviously, healthcare providers to go back to work, or actually anybody, wherever their occupation is, to go back to work after 10 days, assuming that they feel adequately healthy enough, or at least enough energy to go back to work and have been afebrile for at least 24 hours. Now, the other point is, do they feel good enough to go back to work? I mean, a lot of the patients we've seen do have this prolonged fatigue process and some other symptoms that can go on for weeks and even months. And so I think it's going to depend upon to the extent where that occurs. But at least from the standpoint of contagiousness, it's safe to go back at 10 days, and then it's going to depend upon if the person feels adequately good enough to go back to work, whether or not they do.
Thank you, Tom. Question for Chris. Earlier during the pandemic last spring, we saw a decrease in the number of patients coming to the emergency room for heart attacks, strokes, and non-COVID related conditions. Have you, at this point in time in the surge, seen another decrease in those patients coming to the emergency room for their care?
Surprisingly, no. In fact, we've seen an increase because we have now 6 months of a lot of folks not seeing their physician, and they're not taking their meds, and they don't have their prescriptions anymore. And so the people I'm seeing now that are really sick are basically without health care for a long period of time. And so that's actually the answer to that question. It actually has gone up compared to the spring.
That's interesting. Thank you. Melanie, question for you. Can you please explain what a typical medical unit looks like in terms of caregivers and how they prepare to care for patients, what visitation looks like now, and issues along those lines?
Sure. As some of the other panelists have said, we have also at Akron General seen a huge increase in the last 4 weeks. And I had, my dog is over here trying to join in the conversation. When we have our medical floors right now, we have 4 of them full of COVID patients. Those nurses typically are taking 3 or 4 patients prior to going into one of the COVID rooms. They need to, well, let me step that back. All of our staff, anybody in the hospital, is wearing a mask. We are also wearing goggles, face shields, some type of, Chewy is here, some type of face protection. So when we have someone who we need to go into a COVID room, on top of that, the nurses or techs or physicians or radiology, whoever goes in, will have an N95 mask with a regular mask over top of that to help protect it. Your eye protection and some kind of a face shield or hood. We'll have gown, gloves, usually head covering, because it's just easier with the masks on and off all the time to keep some kind of a hairnet or head covering on. And all of that donning takes not 5 minutes, but it takes a couple minutes to safely make sure you have everything on. And then being in the room, if if you need to go out of the room to get supplies, that type of thing, it's very time consuming to try and provide the best care that we can for these patients. Coming out of the room, there's a certain order that we have to remove everything so things don't get contaminated. Plus, that way you're not contaminating your scrubs that you have on underneath. If there would be a patient who tests positive on, I would say, a regular floor, a non-total COVID floor, at that point, we're going to move the patient as soon as we can. Because all of our staff have been wearing their masks and their face protection, we haven't, I can't say never. I don't think we can ever say never. We haven't noticed that our caregivers are getting sick from taking care of patients who are COVID positive because they've been wearing their protection. That doesn't mean to say that we don't have caregivers out. When I left work Tuesday morning, we had 91 COVID patients. 19 of those were in ICU, and 63%, I pull these numbers every night I work, I pull these numbers for the C-suite. 63% of the total number of 91 patients were on vents. I'm sorry, 63% of the ICU patients were on vents. So, it's, if you're in the ICU, you're pretty sick. The other thing that we've noticed is our caregivers in the last 4 weeks, on November 3rd, and I'm not looking at my numbers, but on November 3rd, we had about 25, 28 COVID patients in the hospital. And we had about that similar number of caregivers out having tested positive. Mostly contact tracing shows back through community spread. 4 weeks later, we had 122 caregivers out, and we had 95 patients, COVID patients. So we're seeing almost a 4-fold increase just in that 4 weeks. And that doesn't get us through the Thanksgiving time period of our 2 weeks that, we're anticipating even more numbers. So again, a 4-fold increase in just 4 weeks is a tremendous strain, not only on everybody who's getting sick, but also those who are trying to take care of them, because with over 100 people out who are usually providing that care, it gets really difficult. Our visiting status right now for all of Cleveland Clinic in Ohio, we're at level purple in the state of Ohio, which means we're at the highest, I'm sorry, we're purple in Summit County. And so for us at Akron General, that means no visitors. If you bring a loved one to the hospital, you pretty much drop them off at the door. Our patients are allowed one visit from one person per hospital stay. And it's very sad when you have someone who is very sick and can't see their family or have that support. That's why it's really heartbreaking when you see some of the conversations that people are having via computers, iPhones, however it has to happen. You see the nurses all garbed up, holding a computer for someone before they get intubated because they may not be able to talk to somebody again. And it's heartbreaking. And so the best thing that I can say for everybody, number one, wear your mask, wear it properly, wear it all the time when you're around people who don't live with you. Stay 6 feet away from people and wash your damn hands.
Thank you, Melanie. Question for Dr. File. Please comment on the care of the COVID-19 patient at home. Can you be specific regarding any immune boosting supplements as they recover? And what are recommendations for others in the household?
Okay, very good. Well, I think first of all, let me just stress that, we've talked about these patients who are in the hospital and are seriously ill with a lot of manifestations, but we have to realize that, 80% of the patients that are infected have mild infection. In fact, of those 80%, probably half don't even have any disease. I mean, they've even infected, they're asymptomatic, which makes it very difficult for us to stop transmission. And I think what Melanie said is very poignant and very elegant. I mean, if we all do wear the mask, we're going to be able to help stop that asymptomatic spread. But as far as patients who are at home who have mild disease, basically it's just supportive care. We said get rest, good rest, good fluids. You can take Tylenol if you have a low-grade fever or achiness or a headache, which is very common. And then, of course, if you have progressive disease, such as was said before, I think George said it, then you have to be considered, or maybe it's Chris, but anyway, then you may have to consider going to the emergency room. There's really no evidence that any boosting immune effect can provide further benefit. I mean, it's probably not bad to have a multivitamin or whatever. I mean, there's been many studies with vitamin C, vitamin D, but to date, there really hasn't been shown that using extra of these benefits the patient.
Follow-up question to that. We hear about some of the anti-acid medications like Pepsid. Are they protective if you take something like Pepsid on a daily basis in terms of preventing the virus?
If you're asking me, Costas, I would say we don't have any data to support that.
Okay, thank you. Question for Julie. Someone submitted that they have read that Akron Children's Hospital may admit adults with COVID-19 if things get really bad in the community. Is it possible that Akron Children's Hospital will be full if and when my child may need care for something else or for COVID?
Yeah, that's gotten a lot of recent press since we've gone to the Beacon Journal with sharing some of that information, which in fact is real. I mean, since March, Akron Children's has been prepping and simulating and putting together units to help the surge in the Akron area and the greater hospitals, the greater Akron, Canton area for surge. So we are prepared. Our 6100 floor, which is our hospital medicine floor, is prepared to take young adults up to age 35 with and without COVID to be managed by our hospital medicine service, which are our hospitalist team and our nurse practitioners and physicians on that team. That being said, there is a huge group of individuals that are keeping an eye on that. And while we're doing that for the community to help offload some of that surge, we will be assured to cap that so that we can obviously take care of the pediatric and adolescent population. So I think the community at large, the message there is everyone can feel sure that there will be a bed for a child, but that we are trying to help because we have capacity to help, the sister hospitals.
Thank you, Julie. Question for Dr. Salem. Before you had discussed what diabetes is doing to the COVID patients, let's turn it around. What is COVID doing to patients with diabetes and sugar control, glucose control in those patients?
So it is harder to treat and control diabetes in patients who do have COVID. As Dr. File mentioned, most patients with COVID and diabetes are at home. And for those patients, we usually keep them on whatever regimens they're on and make adjustments with them from home. Patients who are severely ill, though, have increased amounts of counter-regulatory hormones, meaning hormones that help modulate blood glucose levels and work against insulin to keep blood sort of like a check and balance system. So when we get severely ill, our counter-regulatory hormones like cortisol and epinephrine and glucagon and even growth hormone go up. And that drives our blood glucose levels up. So that makes it harder. There also may be a direct toxic effect of the virus on beta cells that makes the beta cells that make insulin decrease their amount of insulin production. So that drives blood glucose levels up. In addition, some of our therapies that we need to employ that are very effective for the virus, like steroids, glucocorticoids, directly elevate blood glucose levels. And patients who are severely ill have to have nutritional needs addressed, and they need more nutrition than usual. So sometimes they'll be on things like tube feedings, and tube feedings can really bring blood glucose levels up. And then finally, as one of our panel mentioned, we are treating patients in areas that we don't usually treat them. So we are kind of treating patients who might have severe hyperglycemia or diabetic or near diabetic ketoacidosis in units where the nurses aren't usually used to doing that. So we're all having to be flexible in terms of how we approach that. So it's a big challenge.
Thank you, Jim. Question for Dr. File. How risky is it to go to the grocery store today, to go to the beauty salon today?
Well, that's going to depend totally on what Melanie told us. I mean, if we wear the mask, we do it properly, we stay 6 feet away, it's going to be okay. And then we also wash our hands and do hand hygiene. The problem is if we, don't follow those mitigation measures, then that puts us at risk. So that's the important issue. So we can be safe if we do these. We just have to make sure that we do it and remind everybody else to do so as well. And by the way, Kostas, regarding that prior question about at home, I guess I should have mentioned, because I'm sure many of our viewers are aware, that there is another intervention that we can do for patients, which is directly related to trying to counteract the virus. And that is the FDA within the last month anyway, granted an authorization for us to use in mildly ill patients that are at home, these monoclonal antibodies. So this would be infusing antibodies exogenously into patients that would help counteract the virus. And we're starting to do that now. And it's hoped that we will prevent progression of mild disease so they don't have to come to the ED and certainly don't have to come to the hospital.
Thank you. A question for Father Jerry. During this recent surge, the Ohio Department of Health has recommended that there be no more than 10 people at a gathering. We have had several hierarchs who have been hospitalized with COVID-19 and a patriarch who actually died of the disease after attending the same funeral. Should the metropolis be allowing divine liturgies live, especially with patients over 65 when it can be done virtually?
Okay, thanks. A good question. There's a lot to unpack there with that. I think just the issue about the 10-person gatherings, that's almost has been something that has been pretty consistent in terms of the guidelines all along, and that really has to do with just allowing people to keep a safe distance. And so I think that when we think about that 10-person maximum in terms of gatherings, we have to think about the space in which those 10 people are located. And I think that's an important consideration to realize, just like Dr. File was just saying, if we are doing the right things, we're going to the grocery store, we're encountering people all day long, but we can do it safely. The churches in Ohio have been exempt from some of the regulations. During the earlier lockdown, the churches sort of voluntarily agreed to really cut back in terms of the numbers of people. The way that we have this set up with our Pittsburgh metropolis guidelines, again, people are wearing masks. We have areas in the church that are marked clearly so that people are keeping a safe distance. We are not using any kind of choirs. So again, to decrease the number of people that are chanting. And in our parish in particular, during this surge, even though we can accommodate safely more people than 30 or 40, but that's the parish has sort of kind of found its own place where we have about 30 or 35 people on a Sunday, which allows for, again, ample space for people to keep a safe distance, and everyone is wearing their masks. People over 65 really can make their own choices about attendance. So, I think the metropolis has not required us to make that decision for other people, especially when we have people who are all ages are going lots of places. And so I don't think it's appropriate for us at this point to tell someone because they're 65 they can't come to their church. So that's a choice that each person has to make individually. And finally, lastly, in terms of just liturgy in person versus virtual. For us, the Divine Liturgy is always, it's a communal event. It's a gathering. It's an assembly. And so, and I think it's important to realize that we can't have a liturgy without at least 2 or 3 people, without having the priest and a layperson as a representatives of being of the whole church, of the laity and the clergy together. And so there is this need for something that is communal. So and a gathering of people. So even though during this time, it's been an important thing for us to be able to provide people to come to the liturgy on a virtual with a virtual experience. It's really not what our experience is supposed to be theologically. And so so it's an important thing for us as a church to continue to be doing that, and to be there and to provide the services for people to pray. And it's part of our well-being that's so important for us during this time. So we're doing all of the things that we can to keep people who want to come to be safe, and providing an opportunity for people to worship virtually. But when this is over, we need people to come back, because we really want to be the body of Christ who gathers at this place and has this encounter with Christ.
Thank you, Father Jerry. Question for George. What are the intermediate and long-term symptoms that a person who has recovered from COVID-19 can expect?
We're seeing and hearing a lot of patients complain of shortness of breath that lingers for weeks in some cases, dry cough, significant fatigue. We had 2 employees in our office who tested positive and came back ready to go. And the first week when they were back, by midday, they were just run down. And this was way beyond, time of infectivity and contagion. So those are the symptoms that we're seeing in the literature, as well as anecdotally and talking to patients: persistent shortness of breath and significant amount of fatigue.
Dr. File, anything to add to that question?
Well, no, I think what George said is that very appropriate.
Okay, thank you. Question for Alex. Is there a role for hospice care, and what have you seen in that specialty during this time of the pandemic?
So yes, there is. I mean, it just goes without saying, when we're seeing the mortality in our older population, and those with comorbidities, with underlying diseases, that's the population oftentimes that we're dealing with in hospice. Initially, what we saw in hospice was that first outbreak that we had in the nursing homes over the summer. We had here in Wayne County, we had one nursing home that we lost something like 18 patients, and almost all of them were hospice patients. They were patients with underlying disease already. And these patients, they are very, very ill. They definitely need comfort measures, like anybody that's death imminent. But these patients in particular are very symptomatic, as you've gathered by the symptoms that have been described by the other docs. So we play a huge role in that. The other thing that we've seen in hospice is we take care of a large percentage of the Amish population. They utilize hospice services very effectively, because they are not believers in doing excessive measures for the older population that isn't going to benefit. They're very realistic about life. And those, we saw a huge spike. And I think in one in one weekend, I had between the Thursday and Monday, 18 patients that were admitted to hospice. Almost all of them had comorbidities. They were all Amish. And this was the initial Amish spike that we saw that made the news. And I think between Saturday and Monday, we had already lost 5 of them. And by the end of the week, they were all gone. So we are definitely seeing these patients coming to hospice, and we are definitely seeing a role that we're playing because they are very symptomatic. There's a lot of pain involved, a lot of shortness of breath, and a lot of these Amish didn't want intubated, put on a ventilator. They just wanted to be kept comfortable, and their families wanted them to be kept comfortable. So that's what we saw. And now what we're seeing, the last of this is the current spike is in the nursing homes. And there are nursing homes here in Worcester that are half or more COVID patients. They have entire units. They are so full of, we're getting 5 to 10 admissions a day to hospice of people with comorbidities with COVID. And they're not surviving very long. They're no sooner than we admit them, we're giving them comfort medications, and they're not surviving. They are having staff that are they're short-staffed, extremely short-staffed in these facilities. And Tom, I don't know what you've seen or what you've been made aware of, but there are COVID positive staff that are working with COVID positive patients just because they don't have the staff, and they're COVID positive, their patients, so they're not going to, the theory is they're not going to hurt them. So if they're capable of working, they're working. And so we're really seeing it's really quite a sight to see when we're doing telehealth visits in the nursing homes and some of these facilities, what's happening. So yeah, so we're seeing it definitely.
Thank you, Alex. And just a follow-up question to that for Dr. File before we go into the next session here. Can you speak to the different strains of the virus? Something that's come up is, okay, I've had COVID. Can I get it again? Will it be a different strain? What are the risks for that and percentages or whatever?
Well, you can get it again. I mean, the thought is depending on the duration of immunity. And if you just had a mild case, your duration of immunity may not be that long. I mean, the CDC now uses a threshold of 3 months. I mean, so that after 3 months, it's conceivable that you could have a new infection. Now, whether you call it a new strain or just a variant, I think is somewhat of a moot point. I mean, we do know that these viruses, all viruses actually tend to evolve as they go through a population anyway, and there are mutations that occur. I mean, the nice thing so far as the mutations for SARS-CoV-2 is that it doesn't seem to affect either infectivity, duration of immunity, or very importantly, it doesn't affect susceptibility to our antiviral agents or to the effect of the virus, to the vaccine. So hopefully that'll maintain. I mean, it's not as changeable as influenza appears to be, but we're going to have to follow this to make sure that this holds true. But right now, of the mutations that have occurred, it really hasn't made much difference as far as the infectivity or the duration of disease, and certainly the susceptibility to our interventions that we have.
Thank you. Question for Julie. What is the recommendation for student athletes regarding return to play clearance?
So this has come up, I think, a little bit more because now we'll talk about, right, not everybody is in the hospital. So you have all this population of relatively healthy individuals and young people who have for the last 9 or 10 months still needed to be out and about. So as schools remobilized and sports have been playing, we really weren't doing a whole lot with any COVID positive players once they finished their incubation period, their quarantine period, or their isolation, they went back to play. But now there is this growing body of evidence, right? You've heard tonight that, the damage to myocardium, there can be cardiovascular effects. All of these recommendations in the American Academy of Cardiologists have really been in the adult population. So there's not a lot of data around what's happening in young adults. However, there's growing concern because we have kids playing and we have had an increasing number of COVID positive players, whether that be in the high school level or collegiate level. So really the recommendations are right now is if you are COVID positive, regardless, and you are over 12 years old, regardless of your symptomatology, whether it was mild or moderate, that you consult with your pediatrician or primary care provider regarding should you be seen by a cardiologist and or at least an EKG echo being done, depending on the severity of your illness at the time. Lots of fear around that. Under 12 years old, it really depends on the severity of your illness. If it was mild, we are typically recommending the traditional CDC guidelines. If they had moderate symptoms or they were hospitalized, then we typically are doing a telehealth cardiology visit with or without some additional testing and procedures. So the take-home message is before you go back to play, make that phone call up and let them, because as Dr. File has said, it's all changing rapidly. So you may not have, you want to make sure you have the most recent information.
Thank you, Julie. We have a number of questions regarding the vaccine, and I'd like to address each of these to Dr. File, if I may, and we'll just sort of go down the list. The first one is, what is currently known about the specific sequencing and timing of the various groups scheduled to get the vaccine?
Well, the CDC has put forth a sort of a prioritization list that they put forth actually several months ago. And then last week, actually, they voted on just what they call tier 1. And tier 1 would be healthcare providers. They want to make sure that we keep healthcare providers safe so we can take care of patients. And then those that either work or are residents of nursing homes, because as I think Chris already mentioned, I mean, they are highly vulnerable. So that is right now what is considered tier 1, and that is what's going to probably take up the majority of the doses that are going to be available through the end of the year. Once that is accomplished, then they'll go to other priority categories. And the next one probably is what they consider essential workers. I mean, these would be law enforcement, education, food handlers, transportation people that are really important for society to function, actually. And then it goes to all of those people that have these underlying conditions that we know are associated with worst outcomes. Jim already mentioned diabetes. Probably the worst one that we see is obesity. But I mean, if you have heart disease, lung disease, kidney disease, or these other conditions, then you'll be in that category. Then finally, everybody over 65. And then after that group, it'll be the whole community. So there's going to be sort of a prioritization as allotments are available of vaccines to be able to administer to the whole population. The thought is by the middle of next year, hopefully everybody in the United States would have at least the access to the vaccines.
Thank you. Another vaccine question. How safe and effective is the COVID-19 vaccine?
Well, I mean, the outcomes that were measured in the studies of the two that are going to be coming out shortly, which we think will be coming out, because as you know, tomorrow the FDA is going to look at the Pfizer study, and then next week it'll be the Moderna study. But both of those had what we call efficacy outcomes of about 95%, which meant that once you get your second dose, because both of these are 2-dose regimens, and then you wait 2 weeks after the second dose, and then they start looking at, the efficacy. Did patients develop disease? And what it meant was that after 2 weeks of the second dose, you were protected 95% against having clinical disease. That doesn't necessarily mean infection, but it means having symptomatic disease. And so that's very good results. I mean, and I also want to point out that these studies were done with very high degree of validity. I mean, there's concerns that, well, this is done in such a rapid way, almost, well, it is unprecedented to have a vaccine available within a year. But that's because there's new technology that allowed these vaccines to be assessed in months rather than what it used to take previously in years. And I really want to emphasize that the safety of these vaccines has been critically evaluated. The FDA clearly established a threshold that patients or these subjects who are in these studies would have to be evaluated for at least 2 months after their second dose before they would even consider authorizing the use of these vaccines. And that's important because if you look at all vaccine trials in the past, virtually 95% of all significant vaccine-related adverse events, at least serious ones, have occurred within 2 months of the vaccine. So the fact that we have all of this experience with these two studies, I think is very encouraging that it should go forward.
And another one, if a person has tested positive for COVID-19 and recovered, should they still be vaccinated?
Yeah, the short answer is yes. The thought is that we don't know the duration of immunity with natural infection. It appears, quite honestly, from the preliminary data, the phase 1, phase 2 studies, that the vaccine actually induces a higher immunogenicity or higher antibody levels than natural infection does. So the thought is you might get more prolonged immunity with the vaccine. Plus, I mean, you can consider it as a sort of a booster effect anyway. So the answer is yes. I mean, if a person's had known COVID, they can still get the vaccine.
And one last vaccine question. Can pregnant women be vaccinated for COVID-19?
Yeah, that's a very good question. Right now, I think we're going to have to wait and see how the FDA addresses that with their EUA response tomorrow. Initially, the CDC said that they would not make it a contraindication for pregnancy, but then they rescinded that. And then they said, well, we have to wait and see what the data is. I mean, quite honestly, in the studies, being pregnant was a contraindication, so you couldn't enter the trials. Having said that, there were many women of childbearing age who became pregnant after they were enrolled into the study. So there's going to be a large number of women who were pregnant during the study that will be evaluated. And so that will be presented hopefully tomorrow so that we can make some type of educated guidance for women of childbearing age. Because when you think about healthcare providers, when you think about our nurses, that's going to be a large segment of our healthcare providers. And so they're going to need guidance on that. And so we'll just wait and see what the FDA says in their review, as well as the guidance by CDC.
Thank you for that, Tom. Question for Father Jerry. Should we apply the same concepts about masking and distance in non-liturgical services such as funerals or baptisms or weddings?
Absolutely. And that's exactly what we are. When you come to Annunciation or any of the parishes in our metropolis, the same things that we are doing on Sundays, checking temperatures, keeping a list of everyone that attends. Everyone's required to wear a mask. We still continue to make sure that the social distancing happens. The only thing that's happened a little bit with some of the sacraments is that we have provided spaces for people who are members of the same household to be together in the pews and those kind of things. And so I have to say, I have to really commend the Annunciation parishioners, because people have been so compliant and so willing to really without complaint, comment, to really just follow these guidelines that have been set out for people to keep everyone safe. So yes, we're continuing any service, anything that's happening at Annunciation. People are following those same guidelines.
This question I'll ask George, Dr. File, and Chris. Question about current treatments for COVID-19. What are considered standard proven treatments for COVID-19 at this time, and what is their effectiveness? We'll start with George first.
Well, as Dr. File had mentioned, the monoclonal antibodies that were recently approved under emergency use authorization really have the potential to be game changers. It's somewhat complicated. It's an infusion, and the patient has to be monitored for any allergic reaction afterwards. And it's indicated for patients with mild to moderate disease. Actually, it's contraindicated to be used in patients who have severe COVID-19 disease, because it actually amplifies the immune response, causing multiple complications. But we've used the monoclonal antibodies at Altman Hospital, and in the reports, of course, we've seen a significant reduction in progression to more severe disease. And anecdotally, in the patients that we've used at Altman, we've seen a rapid recovery and no need for any more inpatient management. Once the patient comes into the hospital, really landmark finding that the use of steroids has been shown to reduce mortality and decrease severity of the immune response once again. Of course, it complicates the diabetes, as Dr. Salem was saying as well. But that was a 30% reduction in mortality in the summer when that study came from the United Kingdom and then was followed up in studies here in the United States. So it's in our hospital, and I think all hospitals, we have a protocolized order set with all the various treatments, and steroids really are at the top of the list. Remdesivir also, as an antiviral, helps to reduce the duration of symptoms, hasn't really been shown to have an impact on mortality. And really its benefit is probably in more mild to moderate disease again, and not so much in patients who are very, very sick. So early use is important. The use of plasma, convalescent plasma, again, probably earlier in disease when the disease is mild to moderate. This is basically a transfusion of antibodies basically from other patients who have been infected and recovered from COVID. And that's a treatment that we are using right now. Anticoagulation, also there's a lot of controversy. There's not a lot of good scientific rigorous studies that have suggested the appropriate dose, but anecdotally, I think there's a lot of push in the medical field to use blood thinners to help reduce the complications of thrombosis, clots basically, that can affect all organs. And the appropriate dose, again, is in question. So that does require a little bit of judgment. There's one treatment for rheumatoid arthritis, tocilizumab, which is an anti-inflammatory medication. Actually just published yesterday or today, I think, in New England Journal. Didn't really show any significant impact on about 500 patients that were studied. But we do know that it reduces inflammation, and so it's kind of at the bottom of our tier of our cocktail for treatments. And then, as we discussed earlier, appropriate oxygen support using the right devices to try to minimize damage to the patient. And then there's all these other treatments that are out there: azithromycin, Zithromax, Pepcid, metformin, the blood sugar medication, vitamin C, zinc. All of those have shown there's been anecdotal evidence, but nothing rigorous. So we really stick with Decadron, the steroids, remdesivir, anticoagulation, appropriate oxygen support, convalescent plasma, and then of course for the mild to moderate disease, monoclonal antibodies.
Dr. File, anything to add to that?
No, George very expertly reviewed all of that, and I agree with it, so I have nothing to add.
Okay. Chris?
No, I mean, he really covered that well, so.
What I may want to ask you, Chris, from your standpoint in the emergency room, do you ever find a situation or a patient that you institute some of these treatments in the emergency room? And if so, which ones?
Well, from an emergency standpoint, the only one that we're doing is supportive care for a patient that's critical. So we're giving intubation, fluids, we're resuscitating even with vasopressors, things that are stabilizing their blood pressure, get their fluids up, keep them alive long enough to get to the extra care. The one caveat that we use is, as they've mentioned, George, is the Decadron. We're giving, the steroid almost immediately. So I recognize that quickly. I give it right away.
Great, thank you. We do want to clear up one point from earlier in the program, and I'm going to ask Dr. File to help clarify this. So we'd stated that after 10 days, one is no longer contagious. At what point does the 10-day count start?
Yeah, I saw that in the chat as well. It starts on the first day of symptoms.
Okay, so the first day of symptoms.
Right.
is when the 10-day thing starts. So
So you can start your symptoms on maybe 3 or 4 days you have the test, but you go back to when the symptoms started to count those 10 days.
very good. Probably have time just for a couple more questions. So again, for Dr. File, it seems that the death rate since the onset of the pandemic has decreased. Why is this? Is the treatment better? Is there a weaker strain developing? Or are we just diagnosing a larger number of asymptomatic patients?
Well, I think it's the first and the third. I mean, with the increasing number of asymptomatic cases, you're increasing the denominator. So obviously the numerator is going to be somewhat, the ratio is going to be somewhat less. And also as all those interventions that George mentioned, we are providing better care and we're getting better outcomes such as reduced mortality. So I think that plays the major role for that.
And one more question for Dr. File. What is the difference between the rapid blood test versus the nasal swab test versus the spit test?
Well, I think we addressed that a little bit earlier, but the nasal, still the standard is the nasopharyngeal swab. The saliva test still is somewhat needs to be evaluated more before it can be generally used. Actually, the one that has been used most significantly still requires a CLIA or a significant lab in order to do the test. What we really need, quite honestly, is very cost-effective, accurate point of care test where, it's almost like a pregnancy test or a strep test where somebody can just have a card, swab their nose and then put it on a card in 15 minutes, they'd have the result. We're starting to get that technology, but we don't have it available yet. So we're just going to have to wait for that.
Thank you. Question for George. Do you give credit to the ABO, et cetera, blood type related relationship to an increased incidence of COVID-19 in the A blood group population? Is that something you see?
I think that's to be determined. The idea that a blood type can be associated with certain infections has been something that's been in the medical literature for decades. And there's some anecdotal evidence for that. And I'm sure there's big databases that someone could look at to look at that specifically. But I can't say in a practice perspective clinically that we're seeing that or using that in any way to kind of proceed with managing patients.
Thank you. A question for Melanie. Could you please comment on the human perspective in terms of nursing staff burnout and what you have seen with that and what you can share with the group on that?
So I think the burnout is a very real thing. I actually just read an article today that said, nurses are always on the front lines, but actually right now nurses are kind of like at the last point. Not only is it physically demanding taking care of patients, period. I have to say that to some extent I'm jaded in that recently hospital stays patients have been expecting to be treated more like hotel guests than actually sick people at a hospital. But nonetheless, as nurses, as caregivers, whether it's techs, physicians, radiology, respiratory therapy, dietary, social work, all of these different people help take care of the patients. And all of them are giving everything every day. You go in and see a patient who hasn't seen any family member, who hasn't seen a friend, hopefully people are calling them on the telephone, but they just want to talk. And you would love to sit and talk with them, but you only have so much time because you have 3 or 4 or 5 patients. If you're on the COVID floor, you might have 6, 7, 8 patients if you're on a medical floor because staffing is so short. So not only are you physically exhausted from taking care of these patients, for 12 hours, which usually turns into 14 hours a day, you're working extra because people are calling off sick. So you have all of that. And then there's the emotional stress of not only being with people who are sick and demanding, because let's face it, when you don't feel well, you're pretty grumpy. And, you've got to make sure everything is done that you can do. You want to spend time with people because you went into nursing because you want to take care of them. You want to help people, but you don't have a lot of time to spend with them. So there's that disconnect. And then there's the fact that you go home every day and you wonder, did I wash my hands enough? Did I wear my PPE properly? Am I bringing anything home to my family? So burnout is a very real thing. And it's not just nursing, it's everybody. It's every single person that is in that hospital providing care, from housekeeping, maintenance, all the way up through the C-suite, who are walking through and doing rounds and making sure that we're doing everything that we can. So again, wear your mask, stay 6 feet away, wash your hands, take it seriously.
Thank you, Melanie, for those perspectives. Well, we have reached the end of the seminar. Once again, many thanks to our medical experts and to Father Jerry for serving on the panel and educating us all on COVID-19 this evening. This has been quite an informative session. And thanks to all of you, the audience, for your participation. We hope you were able to take some things away from this and have a better understanding of COVID-19. Please be safe and follow the recommendations of the public health authorities. And with this, we'll ask for a closing prayer from Father Jerry.
Okay. I want to, just before we say the final prayer, I want to thank Costa and his leadership for the Holy and Mercenaries Medical Society for putting this on. This was an outstanding panel, and we're really blessed to have the just the level of expertise in all of you, and we're proud to say that you're part of our community, and we're really thankful that you're doing what you're doing to take care of people during this time. You have all of our prayers are in our admiration and thanks. And so with that, we'll ask God's blessing upon us in the name of the Father and the Son and the Holy Spirit. Amen. We ask you, Lord, your continued blessing and protection upon all of the members of our community and throughout the world during this trying time. Continue to illumine and enlighten those who are taking care of us, those who are seeking continued treatments and vaccines for the coronavirus. Continue to protect us, grant us health, and allow us to find our way through this difficult time so that we may praise you, the giver of life and health and every good thing. In the name of the Father and the Son and the Holy Spirit. Amen.
Amen.
Thank you all. Good night, everyone.
Good
Thank
night.
you, everybody.
Take care. Thank you.
Thank you.
Bye, docs.